Okay, yesterday I actually ran out of space for recording on my card on the camera, and so I've had to obviously then transfer things and then just try and leave things for today. In this section, I'm just briefly going to finish off where I left things yesterday, and then just very very quickly talk about the axillary veins, because I was going to do that yesterday, and while I'm here, I think I'll probably just briefly throw in the posterior muscles of the upper limbs, so that I can then move on really to talk about pathologies. I'm actually going to be a bit selective now in terms of I no longer look to do all the anatomy in details of the upper limb, because really I have done the intrinsic muscles of the shoulder, but I haven't completed like the biceps, which run anteriorly, or the coracobrachialis, again, which comes from the carotid process to the humerus, or indeed the triceps. And I have not covered the supinators and the pronators of the forearm and hand. So I'll probably will leave that section off, and then just do pathologies. And as I do pathologies, I will incorporate the relevant anatomy, because really I'm just a bit scared that I'm now running out of time, and I know that my grasp of anatomy is it's I have a working knowledge of anatomy, and I think instead of focusing so much more on the anatomy of that's useful in orthopedics, I would preferably like to cover pathologies and then relate that to the anatomy. And so just to complete yesterday, I was talking. I've just looked at the recording, and I was talking about the compartment syndrome, and highlighting that pressure must be relieved, and pressure can be relieved by perhaps removing the cast if the pressure is coming from an external cast, or whatever immobilization that is being used must be removed. If, however, the pressure is actually from the inflammatory process within the muscles themselves, or within the tissues of the arm, really the upper limb, the proximal humerus, then that is a medical emergency, particularly as the nerves, such as the axillary nerves, runs in the deltoid, the nerves of the brachial plexus, all of them run through the humerus, and all the blood vessels to the forearm and the hand run through the humerus. So really it is a medical emergency, and pressure must be relieved in order to preserve the limb, and to keep all the vessels and nerves patent and working. So pressure is usually relieved by making an incision, which then allows which then creates more room and relieves that pressure. And then I think that will complete the complications that can arise from a fracture. And obviously the near classification, yes, I did mention that there are 4 types, so that can go as well. And then I think I now need to look at the rotator cuff injuries. And obviously the rotator cuff injuries are quite important in the sense that the rotator cuff muscles holds the glenohumeral joint together, and they stabilize it. So a loss of a tear or a loss of function of the rotator cuff then destabilizes the the proximal humerus and really causes indeed the head of the humerus to migrate upwards, because then there is nothing, you know, there's nothing working against the deltoids to keep it in place and keep it in that cavity, which, as we know, is a shallow cavity. So just a very quick review of where they are. So supraspinatus, the tendon for supraspinatus, obviously all the muscles of the rotator cuff, their tendons fuse together and they are attached to the bone really as one muscle, but then obviously as one tendon. So, but obviously when we talk about them, particularly in terms of pathology, it's important to refer to them individually, not that they are individual, but to refer to them by their individual names instead of talking about one tendon that is fused together. So supraspinatus is found more superior to the head of the humerus, just under the acromion. If you remember, the acromion lies there. And then we will have subscapularis there. And indeed the subscapularis and teres. No, I think I'm making a mistake. Let's see. So then we'll have infraspinatus here. Just want to look at the model and just be sure. So subscapularis will come, the infraspinatus, teres minor. So we'll have then teres minor will be there. And then the tendon for the biceps will be there. Biceps will be there. I get confused with these two. Sometimes I mix them round. I know I do. I don't know why I do that. But obviously, subscapularis emerges from there and attaches there, while supraspinatus emerges and attaches there. Infraspinatus will emerge and attach there. Teres minor will emerge and attach there. So what have I said? Yeah, teres minor and infraspinatus, and then the tendon for the tendon is actually there. So this would be wrong, right? Because if I have subscapularis this way, I think it makes much more sense. If I draw it exactly as I see it on the model, if subscapularis is there, subscapularis, and then this would be infraspinatus. So subscapularis will be there, and then teres minor there, and the tendon, bicep tendon. Clearly I need to review until I do that perfectly. The bicep tendon is obviously not part of the rotator cuff. The rotator cuff are only 1, 2, 3, and 4. And really, usually rotator cuff injuries are common in both young people and the elderly. In terms of young people, it's usually due to trauma, particularly blunt force trauma, or indeed sports personality. You know, people play a lot of sports, particularly people who play tennis, due to that oh, my racket is just up there. Due to that increased motion of hitting a ball, you know, holding a racket, whether you're hitting an overhand or just you know, returning really a serve or whatever. So it's more about that motion of hitting a ball, which uses a lot of the shoulder, which causes a lot of shoulder movement, and therefore it's that repetitive stress injury, where that repetition of doing a motion then causes overuse of those muscles and tendons, and therefore they will degenerate or become inflamed, and therefore become much more prone to tears. And the one that's mostly prone is supraspinaceus. So an inflammation will occur, you know, as it attaches. So an inflammation might occur, say there, and let's remember the acromion is just there. So this is just disattached. Well, this is the humerus. So this is the muscle, and this is the tendon that attaches it to the muscle. So this is the muscle itself, and this is the acromion of the scapula. So if an inflammatory process occurs there where it's attaching, then really there isn't that much room for, you know, for fluid buildup or for the inflammatory process to occur. Therefore, that then leads to impingement and pain and obviously inflammation. Then there will be a likelihood of a rupture or a tear. I must say perhaps more of a tear, and the rupture could be due to trauma. And with the elderly, similar, you know, the end pathology is the same, as in that there will be a tear, whether it's a partial tear or a full tear. But with the elderly, it's usually due to really the aging process, reduced vascularity, just the wear and tear of muscles and tendons really, or even things like osteoarthritis or caring. You know, these are things which happen to all of us as we grow older. So you know, what happens is there can be a partial tear. So a tear can be partial, or it can be, you know, a rupture. And the management, if it's just a partial tear, it can be resting, again immobilizing and resting, and having analgesia to manage the pain, and anti-inflammatories including steroid injections to reduce that inflammation. However, if it's a rupture or if it's a severe tear, then surgery is usually required to repair that tear, and that can be done by arthroscopy. It doesn't really need to be an open surgery. So then this then concludes talks on the shoulder, on pathologies of the shoulder. And really the complications are similar in terms of you know, loss of function, fibrosis, scarring. So really, once healing has occurred, it's very important to start physiotherapy, to start to introduce movement. So the next section really that I'll very, very quickly cover is the axillary veins. So in really the only reason why I'm covering the axillary veins, obviously because the artery is important in terms of the brachial plexus, and the veins are obviously the veins that are used for clinical purposes when we undertake phlebotomy. These are the veins that have to be accessible, or even for blood pressure really, or heart rate when measuring, I want to say heart rate actually, when measuring heart rate, these are the vessels that we use. So in terms of the contributory veins to the axillary, the main ones will be the cephalic, well I can't believe I don't see it. The superficial ones will be the cephalic, which are the ones which we normally access with ease, and the basilic. And these are just the superficial veins in the arm, in the forearm. The cephalic is at the radial side, and the basilic is at the ulnar side. And they both, at the cuboidal fossa, the cephalic will drain, will contribute to the basilic. However, they will both continue into the arm. So this is called a median vein. It has a few names really. Some people call it an intercubital. So it has a few names, and then they will enter the arm. And as they enter the arm, once they cross over into the axilla, once they cross through pectoralis minor and emerge from pectoralis minor, then they become the axillary vein. And then the deeper ones will be the brachial vein, and it receives it receives blood from the radial vein and the ulnar vein. And again, it joins in with the others, and they all drain into the axillary vein. And if we were to take the axillary vein from pectoralis minor, so this is pec minor. Okay, so I'm drawing it wrong. Really, it should look like more like the tendon is up there and the muscle is like that. But at the superior border of these three have joined really, like they join at the forearm in fact. And then they run under pectoralis minor, and as they emerge, they are now the axillary vein, and they run as they proceed towards the neck and run under the clavicle. So this will be the clavicle. So this is pec minor. So they run under the clavicle and emerge as the subclavian vein. Subclavian vein. And then obviously we then know that the subclavian vein, going back to the cardiology lectures, will then join with, will then merge with the internal, with the jugular, I really should just say with the jugular vein to form the brachiocephalic vein, which, say if this was the right hand side, then this right hand side will join with the left brachiocephalic to then form, I can't remember how much of this can be caught on camera. So if the right and left brachiocephalic will then become the superior vena cava, and then they will drain into the right atrium of the heart. And really, And really, this is all that I wanted to say about the veins. Just to go back to the heart, where we started these lectures, really. And obviously, the importance is its relationship with the brachial plexus, and obviously its relationship as well with the axillary artery, which I think I talked about in cardiology especially. But obviously the most important aspect to note is that the cephalic vein does not have an artery, an accompanying artery. So there is no cephalic artery. So these will be the veins, and then I think I very, very quickly want to cover the muscles of at the posterior. And I think, I really also want to mention that I finally, I went back and reviewed the spelling for serratus anterior. Serratus anterior. Which I was spelling yesterday. Which is innervated by the long thoracic nerve and causes winged scapulae when things go wrong. So the posterior muscles of the upper limb will include, I'll very quickly do them. Levator scapula, let's see. Starting deep. These are the muscles that join at the spine of the scapula, and they run from C1, 2, 3, 4. So it's C1 to C4, and spine of scapula. And all they do is elevate and depress the scapula. So they run, near the scalene muscles. If we remember the scalene muscles which we use for labored breathing, which are accessory muscles for breathing. And obviously the scalenes are also important really in terms of where the roots of the brachial plexus emerge, because as they emerge, they will lie between the anterior scalene and median scalene. So, but anyway, levator scapulae is one. And then we also have the rhomboids, which are attached onto the medial borders of the scapula, and the cervical and the first thoracic. So rhomboids, and that's rhomboid minor and rhomboid major, and their function really is to stabilize the scapulothoracic joint, which is over there. And again, they do as well work in depressing and elevating the scapula, and again moving the scapula. And then another muscle of the posterior, muscle will be, I need a different pen. So we have levator scapula, the rhomboids, which are the rhomboids minor and major. And then we'll have, now we're moving much more superiorly, but we're not yet superior. We'll have the trapezius muscle, So we'll have the trapezius muscle, which will attach at the base of the skull there. So base of skull or occipital. It will also attach at the spine of scapula, at the superior border of the spine. So superior border. And then it will also insert into the vertebral bones from because obviously it's inserted there, so up to C7. So we can just say from that occipital point up to C7. And trapezius it will also insert at the inferior border of the scapula. So based on this attachment, it looks like a trapezium really, where I've not drawn it to you know, as accurate as I probably could. So that will be his attachment on the skull, so OC. That will be his attachment on the spine of scapula, so if you say scap. And that would be his attachment on the vertebra, so it sits there. And then the most superficial muscle, which is the largest muscle, is the latissimus dorsi. I'm actually going to write latissimus dorsi up there. And this is a very large muscle that attaches from T7 up to the sacrum. And it also attaches at the iliac crest, at the spine really. And it will also attach onto 1, 2, 3, 4, so 12, 11, 10, 9. Also, it will also attach onto ribs 9 to 12. So this is a very, very large muscle. If we were to look here, so it will attach there. It will attach all over there, and it will attach into these ribs, the ribs 9 to 12, and also there, both sides, and then it also attaches onto the humerus. So, and then to the humerus. So its attachment, as it flanks, as it extends all the way from the inferior aspect of the human body, it then extends laterally to find its attachment on the humerus. And interestingly, it actually attaches at the anterior surface there, at the lower lip of the inferior tubercle. So it will extend and make a turn like this. So it will extend like, I wanted to show it using a pen. So it will, I'll show it using my hand. It will extend like that and then make a turn and find its attachment there on that lower lip. So it will find its attachment there, together with other muscles that attach there, which include teres major, which really I should mention because it arises from the inferior angle and lateral border of the scapula and attaches onto the humerus as well, while the rhomboids, rhomboid minor and rhomboid major are there. So teres major arises, I don't know if I mentioned it before, so 5 teres major from inferior angle of scapula and lateral border of scapula to the humerus again, so to the shaft of the humerus again, all, so teres minor as well will attach there together with latissimus dorsi. And the nerves, trapezius, is tested a lot, and we test cranial nerve 11, which is the accessory nerve, and usually it's by shrugging the shoulder. Latissimus dorsi is the dorsal thoracic nerve that is tested. Teres major will be innervated by the axillary, and I think in musculocutaneous. I'll need to relook at that because I have not looked at these muscles in great detail, really. In fact, I haven't actually really revised them properly. So these will be the muscles that arise from the posterior surface of the axilla and appendicular skeletons of the upper limb. And then one last muscle that I have not mentioned is the deltoid, and the deltoid is the most superficial muscle of the upper limb. It actually attaches, I don't know what pen to use because I haven't got that many colors, different colors. Deltoid is a triangular shaped muscle. It looks like that. So it will have tendons, tendons. So it will attach at the lateral aspect of the clavicle and at the spine of the scapula and acromion as well. So it covers all that region, and then extend inferiorly to the humerus to attach at the deltoid tuberosity on the humerus. So if you can imagine, it goes there and there, and obviously as it's extending to its attachment, other muscles such as pectoralis major will be there, teres minor is there, latissimus dorsi is there. So deltoid, oh, that's not a good pen for writing the board. Will attach onto lateral. Trying to use a different one. Lateral aspect of the clavicle. It will also attach on the spine of scapula at the superior